Good afternoon, good morning, good evening, depending on where you are in the world. Welcome to another IPC Partners Journal Club. Delighted that John will be presenting today, and we're going to be talking about surgical site infection, patient warming, hypothermia, normothermia, an area that I'm really interested to learn more about. So, John, what's your experience? And hello, John, by the way.
Hello, Phil. Hi, everyone. How you doing? Good to see you.
Um, yeah, I mean, in your day job, is this a problem that comes across your team's desk frequently, and any strategies you're currently using to try and manage it?
Yeah, so it's part of SSI prevention, and it's one of the most annoying areas of HCAI, Phil, to be honest, because it's it's an area that's relatively controlled. So much of what we do is in a kind of uncontrolled environment, and the actions of staff in a busy healthcare environment sometimes seem out of our control. Whereas in a relatively controlled theatre setting where we have elective procedures, often patients
Mm,
going through that we have a lot of time to plan for, why do we still fail to meet those key interventions to reduce SSI? One of which is maintaining a normal body temperature.
yeah, it's a really good point about it being a controlled environment, isn't it? And like you say, within IPC, there are lots of factors that are quite dynamic and out of our hands. So having planned surgery, do you think we'd be in better control? Um, and in terms of interventions, anything in particular that's caught your eye on what might work or support it?
Yeah, good temperature measurement is a good start.
Mm,
We know we're not great at measuring core temperature, and there's some specific nice guidance about how we should do it properly. So it's worth being aware of that. And then I think the message of this paper, Phil, but you're making me spoil the plot right at the start. I mean, the key message from this study that we're going to look at is warming's got to be part of the patient flow. If we start warming a patient too late, it's too late and it's a waste of time.
okay. If you want to share the slides, John, we'll make a start. Thanks, John. So yeah, we're here in partnership with Solventum today. A big thank you to them for partnering with IPC Partners. Um, we've got a really nice rhetorical, is it a rhetorical question? I think we're going to try and unpick it anyway. And this is a really interesting study, really nicely powered. So it's a random observational, multi-centered and pragmatic study. It's a bit of a mouthful, looking at the prevalence of hypothermia on admission to recovery rooms, despite using forced air warming devices. And this was published in PLOS One in 2019. So just before we get into it, and John gives us his synopsis on the paper. If you're joining an IPC Partners Journal Club for the first time, we run these every 2 weeks, um, in parallel with our Insight webinar series, where we go into a little bit more detail about a particular IPC topic. But today we're going to look at one particular IPC published paper. Ultimately, it's all about generating audience participation and discussion. So please use the Q&A box in the top of your bar in Teams, or if you'd like to share any of your perspectives, please use the chat function to share your experience of this topic area. It's an opportunity for continuous personal development, and we'd like it to be a way for you to exercise your critical thinking skills. So don't take everything John says as read. Do challenge and bring your own experience into the discussion. We'd like to think we're building a bit of a network for enthusiasts as well, and ideally we'd like to have a little bit of fun as well. So you can see, if you scan that QR code, all our upcoming IPC Partner Journal Clubs and webinars. We do record the sessions as well. You're all muted and your cameras are off, and we make these sessions available on our YouTube channel as well. So I think that's it. John, over to you.
Yeah, thanks, Phil. So as we get started, just a reminder, if you get your questions in via the Q&A box as we're going through, rather than a flood of questions at the end, it'll make it easier for Phil to work through them to think about the Q&A. Okay, so um, SSI prevention, as I said at the start, is a real exemplar of what's good about IPC and what's challenging about it, in that we know that if we get the key steps of prevention right, we will materially reduce the risk of SSI. However, often it's a struggle to do that consistently and effectively. Um, so uh, Perioperative hypothermia is a good example within SSI prevention, in that we have effective warming technologies and some quite specific guidance, and yet hypothermia remains quite common after surgery, and as we'll see in this study, it puts a helpful number to it. This isn't just a story about SSI and SSI prevention. This is a story about wider surgical outcomes. We know that maintaining normothermia is associated with fewer surgical site infections, but also fewer surgical complications as well. I put out a blog on the IPC Partners website earlier in the week, so it's worth having a look at that by way of background. So I suppose what we're questioning today, based on this study, is why do we have so many patients that come out of theatres cold? That's the key study question, really. So it was an impressive study cited in France, published in 2019. It was a non-randomized observational prospective multi-centre trial. They were looking at adult patients going through surgery. They excluded a couple of categories of surgery. So they excluded cardiac surgery, they included outpatients, and they excluded surgery with anaesthesia lasting less than 30 minutes. Yeah, but that totaled almost 900 patients from 52 hospitals. So it's a really broad cross-section of hospitals from a site point of view. And the thing they were looking at was hypothermia, as defined as a core temperature below 36 degrees on admission to recovery. The study also incorporated an analysis of warming strategies, and there was an analysis, a regression analysis, to look at risk factors for hypothermia. So in terms of outcomes, the main kind of headline big ticket outcome was that just over half of the patients had hypothermia on admission to recovery, which is, I think, quite a shocking finding. I'm perhaps not surprised by it, but I do think it's not a great finding. And that was despite the fact that in 90% of the patients, they had actually been exposed to one or more warming system as part of their journey through the theatres. The study also included a risk factor analysis for patients being hypothermic on admission to recovery. And this was a nice, clear, multivariable analysis. And they found 3 risk factors were significantly associated with having hypothermia on admission to the recovery room. The first was advanced age, more than 70. The second was extended duration of anaesthesia. And the third was a temperature drop of more than half of a degree between induction and surgical incision. So if the temperature was dropping quickly in theatres, you were more likely to get to hypothermia. It kind of makes sense, but I suppose what that suggests is that even if you have a relatively high temperature going into the theatres at the start of the procedure, you were more at risk of hypothermia if that initial temperature drop was faster. There was one protective factor in their analysis of risk that came out. So patients that had a combination of pre-warming and intraoperative warming had a significantly reduced risk of hypothermia on admission to the OR, and that, to the recovery room, and that was perhaps the strongest variable at play in the analysis, with an odds ratio of 0.48. So patients were more than half as likely to come out cold or with hypothermia if they had this combination of warming devices or approaches rather. So thinking about limitations, as ever, it's worth thinking about these limitations so we can try and analyze these studies critically. The study was observational, not randomized, so we can't necessarily make causal associations between warming strategies and outcomes, or any of the other risk factors that were associated. The association with age or anesthesia duration aren't necessarily causal. They could be explained by other factors. Clinical teams continued with their usual practice. There was, as you would expect, across 52 different hospitals, very different approaches to maintaining normothermia. And that wasn't controlled for in the study. They weren't cluster randomized in any way. This was just a cross-section of all the different types of warming. Related to this, temperature monitoring is a key limitation scientifically, because the methods for measuring the core temperature were not standardized, and we know they vary greatly in performance. The study didn't capture occasions when warming may not have been undertaken properly per protocol, and that may have affected the estimates of exposure. Selection bias is always a problem, and could have been at play here because participation was voluntary. And also, the study did not include any downstream consequences of hypothermia, for example, surgical site infection or some of the other complications that are linked to hypothermia. So for discussion then, active warming was used in 9 of 10 of these patients, and yet half of them came to the recovery room cold. So what does that tell us about the difference between having an intervention that we know is effective from the literature and what is actually delivered in practice? And sort of related to that, is that 52%, 53% figure an underestimate given the limitations of measuring accurately core temperature? How do we view pre-warming as part of our surgical journey? Is it considered a core part of our temperature management strategy, or is it an optional add-on that we may or may not choose to do? This study suggests that we should be thinking in terms of the former. How can we address this finding about that high level of temperature drop between induction and incision? Is that a key point for intervention in order to address this problem? Another finding of the study was around temperature loss during transfer from theatre recovery. Sometimes that transfer duration, distance is far. You have to get a patient a long way through a cold corridor from the theatre to recovery, and then from the recovery to the ward. How do we measure compliance? So what are we looking for when we're saying, yes, we have delivered our temperature management strategy? And is that something we audit? Do we have visibility of impact? And could we, if we were to start again with a blank page, what would our kind of whole pathway, gold standard temperature management pathway look like in a modern era, given the technology that we have available to us? So what does this mean for IPC? Well, we know hypothermia is linked to post-op complications and sits within the wider SSI prevention bundle of care, and it even sits in an even wider bundle of care around surgical outcome improvement. Evidence-based improvements will only work if they're implemented effectively. We know that this is true across the whole range of measures that we apply to reduce the risk of infection, that consistently applying them day in, day out is a really, really hard task. It requires behavior change and system level action in order to implement interventions effectively. Could normothermia be used as a bit of a marker of perioperative pathway reliability, alongside things like antimicrobial prophylaxis, skin prep, glucose control, etc.? I think whatever else we think about the study, it definitely supports a focus on timing and continuity around temperature management, incorporating pre-warming, intraoperative warming, effective temperature monitoring, looking at the transfer process in order to make a connected pathway of temperature management, rather than just thinking about what's happening in the operating theatre itself. So Phil, that's it. We're back to you.
Thanks, John. I really enjoyed that and learned a lot. I think some of the facts and findings were quite surprising. Knowing that it's being used warming in lots of patients, but still a high proportion of the patients, being hypothermic. Did they draw any conclusions as to why that was?
Not really. I mean, I think they were able to say confidently that this combination of pre-warming versus intraoperative warming was a major factor in quote unquote success in maintaining normothermia, but they didn't break down which type of technology or device is being used. They didn't look specifically at compliance with interventions, duration of warming, etc. Didn't come across in the paper.
Okay, thanks, John. So please do use the Q&A for any questions that you might have for John on this paper, or maybe something wider around SSI and hypothermia and temperature management. It's a French study, John. So I'm wondering if we look at it through a UK lens, was there anything you picked up upon about the way that they're doing this differently to us in the UK, and anything to learn there, or quite applicable, across various healthcare settings?
Yeah, not especially, but I do think there's a question about generalizability, because we know that there's quirks of surgery and the surgical process in different parts of the world. So I do think it's worth looking across the board at evidence from other settings, because you may well find something quite different in a different country or different surgical setting.
Thanks, John. Okay, the questions are starting to come in. This one's from Nicola. It's quite a long one, so bear with me.
All right.
So regarding hot weather recently and the high temperatures and humidity in operating theatres, are you aware of any clear evidence that makes this dangerous for patient safety or poor surgical outcomes or higher post-op SSI? There's a bit more, but I'll stop there. So anything linking, the increased temperature to poorer outcomes. So that's a tricky one.
Yeah, it's a good question. So I think what it probably would do is reduce your risk of hypothermia in your patient. So that would be a good thing. So your patient would be warmer. We know that ambient temperature is important in terms of temperature management. Actual ambient temperature and increasing the risk of infection, perhaps not directly. There may be some sort of physiological stuff at play, but if you have a really hot theatre, staff are sweating underneath their theatre garb, there's going to be a couple of issues. One is going to be around performance, as in dehydration, inability to see if sweat is getting in the way, and may become more clumsy than otherwise with their procedure, and possibly dripping their own fluids into the wounds and that kind of thing. So I think there could be some indirect knock-on effects on surgical site infection and other post surgical infection risks. Humidity would be another factor to consider. So there's sort of combination effect of temperature and humidity, where you may begin to see visible condensation appearing in some parts of the room, and that may begin to affect integrity of sterile packs, etc. But that's probably likely to be at the more extreme end of things.
Yeah, Nicola actually goes on to talk about condensation, and how this might raise some problems, in terms of promoting the growth of mold, for example. And you've already touched upon really well, like the working conditions for people in a very stressful, chaotic environment sometimes, I guess. Well, maybe not in the elective sense. What was I going to say? I think, isn't that interesting, talking about whether we could link climate change to increased levels of SSI because our temperatures in our operating theatres are going up.
Yeah. I mean, it's not impossible, and I think, but stepping outside of SSI for just a sec, we could see broader climate change introducing just a difference in the microbial makeup of our infection risk in hospitals. For example, we know that in hotter parts of the world and tropical areas, we see things like multi-drug resistant Acinetobacter beginning to come into play, which are not so common in our more temperate climates.
Yeah, good point.
So bringing it back to SSI, you might begin to see your breakdown of different organisms in terms of SSI common causes would change, and you might start to think about your antimicrobial prophylaxis and what kind of agents you're giving.
Yeah, that's a really good link. I think the condensation one as well could be a bad news for the healthcare environment in terms of contamination from some of these organisms as well. I mean, giving them a bit more moisture might allow them to survive a little bit better.
Yeah, I would agree with that for sure.
So when I worked at Oxford, we were doing some work around continuous temperature monitoring, and trying to look at the monitoring patient temperature throughout the whole surgical pathway, from preoperative right through to recovery. I wonder if you have to comment, if you could comment, John, on whether or not you think that has a place in better surgical outcomes.
Yeah, it's funny. I was talking about this yesterday in a different context, continuous temperature monitoring in terms of water hygiene in a hospital.
Okay.
Because at the moment, we know taking periodic water readings from the tap, from the pipes, and that gives you only a very small part of the story. And I think that's the same with our patients going through to take periodic temperature readings, often using suboptimal measurement devices, gives us a very poor picture of what's happening in terms of our real world impact of our temperature management approach. So I'm a big advocate of continuous monitoring of all of our kind of process variables. I think if the technology is there, we should absolutely strive to use it, because it will be uncomfortable, because it will show us much more clearly the prevalence of normothermia, but that gives us a really good baseline then for improvement.
Yeah, agree. What was my second question then I was going to follow on? Do you know if the reduction in core temperature, is linear? So in terms of the further you get away from 37 degrees, the worse the outcomes become for the patient.
I don't know. I don't know the answer to that. I don't know whether anyone's looked at that. Whether you see a kind of a non-linear association between the actual temperature and outcomes. But it's certainly true that temperature loss is not linear. You tend to see it in a big drop off, and then things tail out over time as you kind of tend towards whatever the ambient is.
Okay. Just a reminder, people can use the Q&A box if you have questions for John. There's lots of people online, so please don't be frightened. John won't bite. There's another question, John, but I'm just going to ask the one that was on my mind at the moment. So if you were the authors of this study, and I don't know if there were any recommendations, but where might you go next to investigate this? What would you want to look at?
I think I'd want to try and think about improvement, because obviously 53% of patients arriving in recovery with hypothermia, I would see that as a major risk to the organization or the organizations involved. And the next step would be to say, okay, let's think about what our improvement bundle might look like. So I might be thinking, what temperature monitoring approach are we using, and is that valid? Is it correct? Is it supported by the guidance? What kind of warming approach do we have at the moment? Are we doing pre-op and intra-op warming, which was a clear finding of the study that combined approach is associated with normothermia as an outcome? And if so, which technologies are we using, and are they the optimal technologies for our setting? And then we start to move on to, okay, we've kind of established the technologies we're going to go for. Are they standardized across our organization? I think that's a really important factor, because we see so much variation in practice, especially in theatres, often due to surgeon preference, etc., which is often unwarranted and probably doesn't really help in terms of reducing risk. So once you'd sorted out your technology, then it would be a case of beginning to address the behavioural side of this. How do we then take this kind of package of measures that we have to maintain normothermia, and how do we implement that day to day in a way that actually is repeatable?
Nicola says you're answering her question now. Okay, there's a couple of questions now, John. So Silva says the method used in this study was zero heat flux thermometry, another mouthful, which they don't use in their organisation. Do you know if there is a recommendation on how to measure core temperature in the UK currently, or maybe some précis of what the methods that are available are?
Yeah, there are specific nice recommendations. I'll dig them out and I'll put them into the chat, around the appropriate way to measure core temperature.
Excellent. I'm thinking about linking that to continuous monitoring as well.
Yeah.
Any comment on technologies to measure continuous? There are very few out there, and there is one agreed way, or lots of variation, or you don't know?
Yeah, I don't know the detail.
Okay. Anne-Marie says they aim to get their patients to 37 degrees on the ward prior to transferring to theatres, which is an interesting observation.
Yeah, we've talked a little bit about sort of pre-op, peri-op, and recovery, but actually the patient pathway goes beyond that, doesn't it? You often have an inpatient stay before surgery, depending on the pathway into the kind of theatre complex, and you often always have a period of stay post-op outside of recovery. So whilst the data outside of the kind of theatre complex is less well understood, hypothermia in those settings is going to be bad news. It's not going to be good for patients to be hypothermic. So I think temperature management outside of the theatre complex should also form part of our part of our approach to this.
Susan says they've done a QI project on some of this work at their organisation in Southampton, and happy to share. So yeah, maybe drop us an email, Susan, and we'll see if we can connect on that. We're always willing to hear good case studies. So in terms of IP involvement, John, or IPC involvement in warming, they're not going to play a big role in the day-to-day of patient warming. So do you think this is a priority for infection prevention control at the moment, or it's considered to be a little bit outside of their remit because it's linked to more surgical pathways, etc.?
I mean, I think that's quite a big question, Phil, and it's almost a philosophical one about where does IPC sit on SSI prevention in general. In my mind, SSI prevention fits squarely within the remit of an IPC team. And absolutely should stand over it, should know their infection rates across all the surgeries that they're undertaking. There should be resource allocated within the team to SSI prevention and improvement. But not all organizations see the world quite that way. And I think SSI and SSI prevention is seen by some as sitting outside of IPC, more in the surgical setting within individual disciplines.
Yeah. And I guess that's one of the complexities, isn't it? And I feel like we've talked about this before, is that if there is confusion about where the responsibility lies, then it often doesn't get the attention or the focus that it needs.
Okay, I can come back to you on the methods of temperature measurement. So there's nice guidance, which is nice guidance in UK, which is CG65, and it talks about using either a direct measure of core temperature or a direct estimate that doesn't differ by 0.5 degrees of a direct measure. And it gives some examples of body sites that could be used for a direct measure of core temperature. It talks about zero heat flux as a deep forehead method. It also says do not use certain indirect measures like infrared tympanic, infrared temporal, infrared anything really, or forehead strips. So there you go. There's chapter and verse on temperature measurement.
It's an example of how to do a journal club. Don't know the answer, go and look it up.
Well, that's it. I mean, not everybody knows everything.
No, I've given you praise.
Yeah, I was taking it.
I think we've talked a little bit about this, but Nicola's talking or asking about where the pre-warming process starts.
Yeah.
And we've had people share their experience that it starts pre-operatively in the ward. I guess I would agree with that. The earlier the better, as long as it's close enough to the surgery. But any thoughts from you, John?
Yeah, the study did look at some timings of pre-warming, and I think that the recommendation was to start pre-warming at least 30 minutes before they go into theatre, because that gives time for the technology to work. There's no point in putting the thing on whatever the thing is, whichever device technology you use. 10 minutes isn't going to be enough.
Going back to the comments around the warm weather, the prospect of somebody trying to pre-warm me in pre-surgery
We might have to pre-call you.
Yeah, to pre-call me. Yeah. So we've talked about linking warming to SSI and the role of IPC in that. But where do you think the real responsibility for warming lies, within that surgical pathway? How would we optimize it, in your opinion?
It's a really good question, isn't it? I mean, I think you could look at a surgeon, the person who is really taking ultimate responsibility for the procedure that's happening, um, as being ultimately in charge of these kind of measures. I do know some surgeons who will not begin their procedure until they have assurance of normothermia. That's not always the case, but that really should be the way things go. There's a nursing workforce who will be delivering these sorts of technologies. ODPs as well, I think, are an increasingly important workforce in this space, and take a lot of responsibility, I think, for this sort of approach. So it kind of cuts across disciplines.
Hmm. Hmm. Yeah, interesting perspective. I think ideally having a pathway and some kind of maybe responsibility matrix could really help. I think it goes back to the age-old question around you could have the best pre-warming or patient warming device, but if nobody knows how to use it or nobody's doing it at the right stage of the pathway, then it becomes redundant.
Yeah, that's right. That's it. And then it comes back to human behavior, doesn't it?
Yeah,
We've got to make sure, and I suppose culture as well. If the culture of investing time in making sure we're maintaining normothermia, and that, to be honest, that probably goes hand in hand with other measures. As in, if you have a culture where you're maintaining normothermia, but you're not bothered to keep an eye on antimicrobial prophylaxis or good quality repeated skin prep, that doesn't make sense. So I think it's a case of trying to keep an eye on all of those bundles simultaneously to make sure we're providing prevention for our patients.
yeah, agree. There's something in my mind about when we had Luke on, Luke Moore on recently, talking about impact of AMR on the patient. And I'm just thinking if I was a patient and I had my surgery cancelled because the surgeon refused to operate because my temperature wasn't right,
Yeah.
then it could be extremely frustrating. And, who knows when you're going to get that opportunity for the surgery again, right?
Yeah, that's true. But then on the flip side of that, what if I'm a patient who is informed around risks of SSI and poor surgical outcomes, and I begin to ask you, well, can I see the record of my temperature throughout the procedure? How can you assure me that normothermia was maintained? So I think that patient perspective could work both ways.
That raises a really important point in my mind. So is there a need for more patient education around the risks of hypothermia? And is there stuff that the patients could be doing, before their surgery to support maintaining optimum body temperature?
Yeah. Um, Woolly hat and gloves on the way into theatre. Yeah, that's true. I mean, I think honestly, the thing a patient could do, which is a hard thing, is be fit and healthy coming into the theatre. We just know that patients who are fit and healthy, not overweight, etc., just generally do better with any kind of theatre procedure. That's not something that can be changed overnight. I don't think maintaining a higher body temperature, way before your procedure is going to help much,
Yeah,
because your body loses heat relatively quickly. Um, but I think being aware of the risks, and where possible, speaking to staff about how you're feeling, when you can, that probably would help as well.
yeah. And the education actually around, for example, reducing your alcohol intake, losing weight, smoking cessation before surgery is, in my experience, is really good.
Yeah.
There's plenty of it, because those outcomes are really well linked. There's a comment from Sonia. Hi, Sonia. Good to have you on. Sonia led a quality improvement project on improving pre-warming for elective patients. Staff were taking patients to theatre through the coldest corridor in the hospital. This was a cost-free measure adopted, which made a huge impact on maintaining pre-op normothermia and improving patient experience. Of course, other measures were also adopted, and it's key to have the whole surgical journey included. Couldn't agree more.
Yeah, so that's really interesting. It talks about the physical journey through patients, and we talked briefly about the journey from, let's say, ward or pre-op to theatre, and from theatre recovery, and from recovery to the downstream ward, sometimes those journeys can be relatively long, and sometimes they can be really quite cold. So rerouting, making sure we're maintaining the ambient temperature in those transfer areas could be a significant part of the problem. I'm really interested to hear somebody on the call has had that experience of leading a QI program around maintaining normothermia. So relevant to what we're talking about today.
Yeah, and it's going to happen again, John. There's going to be there's loads of comments that I'm struggling to get through now, right at the end. Maria says, yes, culture and surgeon engagement on SSI surveillance is as important on all the SSI bundles. Do you agree with that?
Yeah, I do. I agree completely. I wonder if we took a straw poll of surgeons and said to them, where would you rate normothermia in terms of the things that you're responsible for that influence patient outcomes? I'd be interested to see what we found. I imagine it would be a mix of reviews, with some people saying, well, I expect the patient to come to me not warm. It's effectively somebody else's job, right through to a surgeon who's absolutely fully engaged in the process and leading the QI improvement.
Is there a gap for a study on facilitators and barriers to patient warming or maintaining normothermia?
Yeah, there definitely is, and I think that would be helpful. So I think there's a gap for some quantitative research around the impact of making changes in the clinical environment and seeing what happens and how we can achieve normothermia more frequently. But there's also definitely space for some qualitative work around why patients are often hypothermic and why we don't manage to achieve the prevention measures we should.
Yeah, there's some comments here on barriers. So patients coming in on the morning of surgery, first case get ready, in a rush with blood tests, taking priority over pre-warming, staggered admission times, and challenges with current wait lists. Often surgeons don't want to delay any further to the start of the list. So, that's a consideration.
I mean, I get it. Patient throughput is a huge currency for an NHS provider at the moment, and an elective, throughput is a big part of that. So we don't want to do things that set us up to fail and create tension at the front line. So I think we need to be canny in the way that we establish and normothermia pathways to make sure they're integrated with the pathway and not interrupting other things.
Yeah. It's an interesting comment from Nicholas saying that pre-op education for SSI risks is something that often gets lost in the high volume of information that our patients get.
Yeah, that's true. And staff as well. I'm sure if we talk to staff around the importance of normothermia, quite a number of staff wouldn't be so on message about how important it is.
Mm-hmm. Louise says we started using warming blankets for pre-warming and the core temperature dots that go on the patient's foreheads. Unfortunately, they're now considered a luxury and due to cost challenges have been withdrawn, although the anaesthetist did not like the forehead dots.
Yeah, interesting.
So we've got two studies that we needed to do, John. One is the barriers and facilitators one, and then another one is on the cost effectiveness of core temperature monitoring.
Yeah, I think that's fair enough. So there's a range of technologies and approaches to look at for sure. So if one isn't working for you and your teams, there are other options. And cost effectiveness is critical, isn't it, in everything we do? I'm pretty sure we can make the case for a cost effective patient warming intervention, given the impact on interventions, on outcomes rather.
There's another comment here around do we place enough emphasis on patient involvement for preventing IPH for elective procedures? Patients should be informed that theatre environment is cold and encouraged to wear or bring warm clothing, such as dressing gown, in line with NICE recommendations. Are any organisations incorporating this into routine practice? Something you do at Guy's and St Thomas's, John?
Yeah, absolutely. Our patient information is better than anywhere, of course. No, I mean, there's always room for improvement, isn't there? But yeah, I think those simple recommendations around remembering that it's going to be cold and wearing warm clothing where you can. I mean, I said hat and gloves jokingly, but in seriousness, warm clothing is a good thing. and may just help to maintain that normothermia.
There's a lot of QI work going on in this space, clearly, but improving temperature measurement by education and providing temperature monitoring devices in the first place led to improvement. Temperature was not even measured in a lot of patients. So I guess until you start looking, you might not even realize that you've got a problem.
Yeah, that's true. And I think unless you're looking with appropriate methodology, you may end up with false assurance. So yeah, going back to those kind of temperature monitoring methods, those are going to be the starting point, I think.
One of my old team from Oxford is on the call. Hi, Bart. Says that they're currently collecting data on pre-op warming using a pre-warming gown. So that would be interesting to hear.
Yeah, good. I mean, that would be good to see what impact it has ultimately on maintaining normothermia.
We've probably got time for one more, John.
Okay.
But I'm running out of questions now. Anything, this has sparked your interest to go and look at a bit differently, or, where are real gaps in our understanding or of the literature? Where would you like to see it go next to make the most impact in this space?
Well, maybe I could do something different, which is to give a bit of a kind of takeaway summary from my point of view. So
That'd be
I
good.
think based on the findings of this study, that 50%, half of patients hit recovery with normothermia. I want to know whether that's true in my organization. So that's a reasonable thing to start thinking about. How do we measure temperature throughout our theatres? Are we carrying risk around normothermia that's modifiable by improved patient management of temperature? I'm interested to review what our temperature management approach is from kind of before pre-op, right through to post-op after recovery. Might be worth walking the journey from into your theatres and out the other side to see whether you've got any freezing cold corridors. Simple things that could be changed, and a system level impact that would reduce your risk of hypothermia.
I think that's a really good way to finish. Go and walk that patient journey and see and experience it for yourself. Okay, John, thanks very much. Always wonderfully presented. And a big thank you to Solventum for partnering with IPC Partners on this journal club. Just before we finish, very, very quickly, I need to learn how to start at a different slide. So our next Insight webinar is with Izzy Centeligi. Izzy will be talking about managing infection risk from hospital sinks and drains. This is a topic that is really close to John and I's heart. So Izzy's now working in Australia. I had the pleasure of working with Izzy when she was a PhD student here in Cardiff, working on dry surface biofilm. So really interesting to see the work that Izzy will be presenting from her experience in Australia. That's at a slightly different time because Izzy will be dialing in from Australia. So that's at lunchtime on Wednesday, the 9th of September. You can subscribe to the IPC Partners Journal Club Insight webinars and other updates from us. We regularly publish blogs on papers that we're going to review as part of Journal Club or Insight webinars. We won't spam you. We'll just give you some interesting updates around topical IPC developments. But we do Journal Club and webinar very frequently, so you're likely to get an email a week from us. Okay, that's it from us. Thank you again to Solventum for partnering with IPC Partners. A huge thank you to John, and thanks everybody for all your engagement and participation. And please share this recording with your colleagues in the future. Thanks everybody. Take care and enjoy your day.